then, huh? Yeah.
Does anybody have to be somewhere urgently?
Yeah, it was such a great first experience. I feel like they're like super thoughtful and do such great work.
Good.
So, you know,
Can I
felt
just
like I was
ask
super
you that
lucky.
everybody takes off their badges?
And as you went to do your PhD at Stanford?
No.
No, postdoc this time.
Yeah, please, and no playing with bones.
Off this, I
We're
guess.
trying to keep this as clean as possible because it's been live webcast. So if you move your badges around, that'd be great.
Yeah.
Okay.
Remember to speak and keep the microphones fairly close. Has everybody met Jamie from the union? Have you met everybody at the press conference?
Yeah, I just met you.
Okay. Are you clear on more or less what I put in the notes? It's just more we've got that. It's a reflection of really what's on it. So now
Yeah, where are you at?
I'm at Imperial College in London, but I rarely go there to be honest.
You've like,
I'm based full time, yes.
so you're all the time 100% in Peru, or?
Pretty much.
Okay.
I don't know who's
That's the way to do it.
Yeah, it's good. And we're
So
expanding now
Michael's?
to Iquitos.
Michael, is that
as well.
Michael, is that yours?
You're expanding in Bolivia too? Okay,
Yeah,
cool.
hopefully. It kind of depends on funding, but we're doing some pilot work.
Okay, cool. Yeah. Are you working with
is that
Bob
yours?
on that? Or,
Yeah.
Because I know he's done some like Chaga stuff
Yeah.
in Bolivia, so he has like
Bob
that
has
guy
networks
is unbelievable. Yeah.
He really is. Like, he's 80.
I know. Yeah.
He's in Peru like at least once every 2 months. Does this mad 10-day trip where he goes Lima for a few days, Iquitos for a day, then goes to Bolivia for a few days.
It sounds exhausting, and I'm
He's so passionate about it, like just
I
the
know.
science.
Afterwards, yes, yeah, I said,
He's,
okay.
yeah.
Yeah.
If I get like, I don't know, a quarter of a career that he's had, I'll be fine.
Yeah. I think its biggest impact is the people he's trained.
No, for sure. Yeah, for sure.
Leo, you've got to rush. You're the only one who does have to rush, right?
Yeah, I have a abstract after this. Yeah. So,
You've got the session.
yeah.
So Jamie, I think everybody here, Matthew, do you have to run somewhere? Or
No.
You don't have to. So everybody can stay for questions after, except for Leo. He's actually got to present the abstract straight after. So we've actually swapped the order so he can actually be here.
What time do you estimate finishing? Maybe I could stay for the questions.
He will be
Depending.
finished by 4:15.
So I think I could stay for the questions.
What time is the session finish?
Finished at 11:45, and I asked to go last.
So 11:30.
So I think there's probably it's tight. Yeah, it's tight. Okay.
I don't want your chair calling me. so
Yeah,
I'm
yeah,
very
maybe
good.
maybe not.
It's up to you.
Okay.
Where's the session? Do you know how
It's
far away it is?
downstairs. Yeah, it's close.
Okay.
Yeah.
What else? So let me just run through what's going to happen. Jamie is going to make a few introductory remarks, reflect on last night's opening ceremony, reflect on the vaccine announcement from the other night, as a segue to talking about prevention and how it's a key, it's one of the key things we're trying to push at this conference. Then she will introduce each person one by one. Everybody will speak for 3 to 5 minutes. The importance here is we keep it tight, short. A good speech is a short speech. We want lots of questions from journalists, obviously. And then at the end of everybody speaking, she'll open it up to the floor. The journalists will come behind the microphones. They'll introduce themselves. They'll say who they are and which outlet they're from and who they want to ask the question to. If there's a question that you think a number of you can intervene on, you can just let Jamie know and say, I'll also answer that question. It's being live broadcast globally, so bear in mind that there are a lot of people watching. It's actually the most important than the people sitting here in this room. And that you will also be able to watch it after the broadcast as well. That's basically it. And then Jamie will say at the end that most of the speakers here can hang around for 15 minutes, and I imagine quite a few of the journalists will come and speak to you one-to-one as well.
Okay.
Okay? Any questions? No?
Pretty good, Michael. Thank you.
Great. We'll start in 5 minutes here.
Yeah. When did you arrive? In India?
2 days ago. It's kind of all a blur.
Yeah. So they had a long way to come from the States.
Yeah, I was also in China.
Okay.
I was in China for a week. I work with a group there, China CDC, for some work there. So I was there for a week, but just travel, a lot of travel, you know. What about you?
Tuesday night, I got here.
Did you go to the TV side? fine. So
I didn't go now. I was planning on going to stuff yesterday, but then I ended up just going to this.
yeah.
But that's it. One year I'd like to come in for like the whole week. Just getting time.
I think 1 year I'm just gonna submit an abstract.
Yeah, just come and enjoy it.
Come and enjoy it. 'Cause like one big problem I have is I submit an abstract and when I don't see other people's work, and it's just like that's one of the main points.
And this time, because there's some really good stuff being presented.
Yeah, super good.
You end up doing a presentation, preparing a presentation, so you don't get around to
Yeah,
seeing it.
and it's kind of a shame, you know. So I think one year I'm gonna do that. We'll see. I keep saying that, but
It's hard not to submit an abstract.
yeah, seriously, yeah. Like my mentors, you know, they push for that. So.
Is your mentor the guy that just did the the plenary?
Yeah, I wasn't. I actually missed it.
It's very good.
It's very good. Okay, good.
Really nice summary, very concise.
Yeah, but he's a good speaker. He's good at everything. But yeah, that's
I guess because he was just citing the work.
Really? Yeah, he
Martinez
told me he was gonna cite some stuff. That's nice. Maybe hopefully they can do that. I can watch it later.
Everybody to turn off their phones and put it on silent mode. Being webcast live.
Just turn this on.
I'm not doing it. Just get a speech test.
Yeah, seriously. It's like I'm nervous.
It's less intimidating because they're all journalists. Scientists.
I think it's more.
It's intimidating. The camera's intimidating.
Yeah.
Knowing that people are watching it online. Excuse me.
Okay, let's start, Jamie.
All right. Good morning, everyone. Good morning, everyone. Welcome to this official press conference in prevention that we hope will set the tone for the coming week ahead of us. I'm Jamie Thonsing. I'm Director of the Union Southeast Asia Office and also the Deputy Executive Director for the Union. The Union is, of course, the custodian of the 50th Union Conference on Lung Health taking place this week in Hyderabad. And I must say we are all delighted that the event is attracting a lot of media attention. I'd like to say a few things before introducing my esteemed guest sitting with me here today. But before doing so, let me run through a bit of housekeeping. This press conference is being live streamed on the conference YouTube channel, and an archive recording will be immediately available on the conference YouTube channel. To those of you who are joining us online, a warm welcome. Today we will be hearing brief remarks from all our speakers, then I will open it up for your questions. We have microphones set up at either side of the room, so we ask you to line up behind them if you would like to ask a question. We ask that you state your name and that of your news outlet and indicate who you would like to ask the question to. Please keep your questions brief. Once the press conference has ended, you can approach a number of our speakers for one-to-one interviews or arrange a time to do so later. I do know that some of our speakers need to be back in sessions immediately after this. Let me briefly say two things to set the scene today. Last night's opening ceremony, I think you would all agree, contained some stunning moments. None more so than the performance and speech by TB survivor Nandita Venkatesan. If you were not there in person last night to see Nandita's appearance, I urge you to do so later. There was something so powerful to see a young woman performing a dance which she could not rehearse not so long ago because she had lost her hearing from taking TB drugs. But we are failing many women like Nandita. We are failing them for many reasons, but a key one is that we have so far, for too long, neglected prevention. This has to stop. By now, I hope that the message from this conference is coming loud and clear. Wherever we treat, we need to prevent. We've announced some great progress on a vaccine announced earlier this year, but while we wait for that to move into its next phase of development, we also need to scale up prevention at all levels. So I think today's press conference will finally draw a line in the sand on prevention. Today we are going to hear a combination of some fascinating research around prevention together with some major announcements on drugs and trials. Before I call on the speakers, I would like to bring your attention to an issue brief prepared by the Union called Advancing TB Prevention. I think this sets the tone for many things that we'll discuss today, the rest of the days in the conference, and the conference that will follow later. With that, let's hear from our speakers. Our first speaker, Matthew Saunders from Imperial College in London. Matthew will talk to a truly groundbreaking piece of research around prevention conducted in Latin America. Matthew, please go ahead.
Thank you very much. First of all, thank you very much for the invitation. It's really great to see the strong focus on prevention at the conference. So I'm here as a representative of the Innovation for Health and Development Research team in Lima and Peru. And on Saturday, I'm going to present in the late breaker session the results of a cluster randomized trial of socioeconomic support to improve TB screening and preventive therapy completion among household members of TB-affected households. So to give you some background, first of all, as we all know, TB is the archetypal disease of poverty. Poverty increases the risk of TB through various factors such as undernutrition and overcrowding, and TB exacerbates poverty by increasing costs and reducing income, and importantly by causing stigma and discrimination. And the WHO recognises this and therefore recommends social and economic interventions for TB-affected households, but evidence for these interventions is required. So over the last 5 years, our research group has built on the work that we've previously done in desert shanty towns and urban communities in Lima, and we did a cluster randomized trial in 32 communities of northern Lima. And essentially what we did was in 16 comparison communities, TB-affected households, so patients with TB and their household members, were randomized to receive National TB Programme Standard of Care, so that was free TB treatment, free screening for household members, and free preventive therapy, free of direct charges. And then in 16 supported communities, TB-affected households were additionally offered an integrated socio-economic support package. So social support was led by TB survivors, who we call peer mentors, and it constituted household visits and monthly community meetings that we call TB clubs. And essentially that intervention aimed to reduce TB knowledge gaps and used a cognitive behavioral therapy framework to reduce TB stigma and discrimination. And the economic support constituted cash transfers, which were conditional on patients taking their treatment and on household members completing screening and taking and adhering to preventive therapy. So essentially, taken together, these interventions aim to socially and economically empower individuals to access the TB care that was being provided free of direct charges at local health centres. On Saturday, I'll present the full results, but just to give you a taster, the results are very encouraging. So household members in supported communities were significantly more likely to complete TB screening. So they were more likely to have a consultation in a health post, more likely to give a sputum sample for testing and have a chest x-ray. And that's very important because we think that by improving access to these health services, we will detect more TB in household members and detect it earlier. And the effects of the intervention on preventive therapy are really quite striking. So household members in supported communities were much more likely to start preventive therapy. And once they started preventive therapy, they were much more likely to adhere to and complete the 6 months of therapy that's recommended in Peru. So that's very important because we hope that by increasing access to preventive therapy, we'll prevent more TB in high-risk household members. And the intervention specifically focused on high-risk household members, so children under the age of 15, and adults who are classified as at high risk using a locally derived risk assessment. So that's all I'll say for now. Essentially, this is an important study because it provides rigorous evidence demonstrating the potential of these social and economic interventions to improve access to care. And the study will be completed towards the end of this year. So thank you very much.
Thank you, Matthew. Our next speaker is Leo Martinez. Leo is a postdoctoral research fellow from the Stanford University School of Medicine. As you all know, the TB and diabetes co-epidemic is a major issue for us working in the field, and nowhere is it more present than here in India. Leo has done some exciting preliminary work around the early phases of infection in diabetic patients that we hope will help our understanding of the correlation between the two. Over to you, Leo.
Thank you. So thanks so much for inviting me to talk here about some of my work. It's really exciting to be here with so many amazing researchers and programmatic people and advocates. I'm going to talk later in the conference about a project that we've been working on for the past 3 years of preventive therapy among diabetic patients. And so diabetic patients are at increased risk for TB compared to non-diabetic patients. But interventions have been mostly focused on screening and not as much focused on prevention. And the main reason for this is that there's not a lot of evidence for preventive measures for diabetic patients. And so there's no clinical trials among diabetic patients for preventive therapy. There's very, very few observational studies on preventive therapy among diabetics. And so we have this very high-risk group that we don't have any evidence to prevent disease with. And so and diabetes is increasing around the world, and it especially is increasing among poor people. That really affects tuberculosis patients as well. And so this is really concerning, and we need new tools to combat this. And so we use this collaboration that we've been forming over the past 3 years. We contacted groups with household contact data and asked them if they wanted to collaborate. They had to have previously published a paper on household contact data, and we asked them, are you willing to send your data to us and make a large, basically global data set? And we weren't sure how people were going to perceive that, but actually everyone wanted to collaborate. It was really a huge success. And 46 study groups from 34 countries came together and contributed data. And what really happened is, one group, it's hard to answer some tough questions, research questions. But with 46 groups together, you can answer some of these really tough, important questions about screening, but about prevention also. And so we found, we limited our study to only diabetics with tuberculosis infection, either with a tuberculin skin test or a quantiferon positive test. And we looked at those that were given preventive therapy and not given preventive therapy, and to see if the group that was given preventive therapy was at lower risk for TB. And we found approximately 84% protection against progression to TB. And so this is really encouraging to us, and we think this is potentially some of the first evidence for preventive therapy among diabetic patients. Whether this can or should be scaled up at a population level is something that needs more work and more research and some creative ideas about how to test that. But potentially is a first step in order to potentially use preventive therapy as a side intervention with screening as well. Thanks so much again. If you have any questions, I'm here.
Thank you, Leo. Our next speaker is my colleague, Valerie Shobha, who is a pediatric TB consultant to the Union. Valerie will talk to the final results of the TT study carried out in 4 Francophone countries around child TB prevention, one that we hope might become a model for prevention in the future. Valerie, please go ahead.
Thank you, and thank you for inviting me to this press conference. So I will talk about children, because all of you know now that children have a less access to a lot of TB services, and actually less than 25% of eligible children who could benefit from preventive therapy access preventive treatment. And the investigation at home of the people who have pulmonary TB is a very great opportunity to identify those children who are sick with TB and also to prevent TB in eligible children. So it is a activity which is strongly recommended by WHO, but it's very, it's not fully implemented and documented in resource-limited settings. And since a few years, we have a great opportunity also. We have shorter regimen for preventive treatment, and especially we have this 3 months regimen with a combined isoniazid and rifampicin using child-friendly formulation that is provides recommended dosage for children. So we did this TT study in 4 countries in Africa, in Benin, Burkina Faso, Cameroon, and Central African Republic, with the aim to demonstrate the feasibility and document the effectiveness of contact investigation and preventive therapy for under 5 children, using the 3 months RH regimen in 3 of the 4 countries, in programmatic conditions. So briefly, the patients were recruited at 13 TB clinics in the largest cities of the country. And all of the patients newly diagnosed with TB were eligible to enter the study if they had children at home and if they were resident within 5 kilometers of the clinic. And so we had a screening algorithm with clinical, during the home visit, if the patient accepted the home visits, the children were screened with clinical examination, questionnaire, and they receive a TST, a tuberculosis test, and a systematic chest X-ray. And they were referred to a doctor if they have a screen positive at this first screening. Briefly, we enrolled almost 2,000 children. And what was interesting is that 93% of the eligible patients accepted home visits. And we could detect 56 cases of additional TB cases in children. That is 2.8 prevalence of TB among the children enrolled. And among the children free of active TB, most of them could start preventive therapy, more than 90%. And among those who started, 94% completed it. This was very important because this was done within the programmatic condition, but with additional resources for key elements, that is the transport of the family, the transport for the home visits, and the phone contact with the family. The adverse reactions were quite mild, and children could be followed up for every 3 months, up to 12 months after the completion of the therapy. And we recorded only 1 case of incident TB during the follow-up, which suggests that the regimen of preventive therapy were very effective in preventing TB in the course of the follow-up. So the first, to our knowledge, this is the first study which uses the shorter regime of 3RH in high TB endemic settings, in programmatic conditions, with a follow-up after the treatment completion. And we think our results suggest that investigation and preventive treatment is really feasible in the context of the national TB programs, if additional resources are really secured for key activities. And that the short regime is quite, the shorter 3RH regime is a quite valuable alternative. It's well accepted by children, is shorter, and actually is less costly than the standard regime when using a dispersible formulation. So I will present the final results of the study tomorrow morning in the oral station. Thank you very much.
Thank you, Valerie. Our next speaker is Robert Matiru. Robert is the Director of Program Division at Unitate, and he'll provide some context to an announcement that will follow his talk. Over to you, Robert.
Thank you very much for hosting this press conference. I think, as all of us know, 1/4 of the world's population is infected with latent TB. And 5 to 10% of those are at risk of developing active TB, which can actually kill them or make them very sick. We know the statistics. Last year alone, in 2018, 10 million people developed active TB and 1.5 million people died. And we know that this is still just unacceptable. A year ago, many of us heard at the high-level meeting in New York, when heads of state, heads of agencies, and a multitude of other stakeholders met to issue a political declaration on what needs to be done to really drive the elimination targets for TB by 2030. They all agreed, among other things, that effective TB prevention was going to be key, and something had to be done about it to really deploy it as a critical tool to helping reach TB elimination. Only 1.8 million people today are on preventive therapy, and not a very effective preventive therapy at that. The target set at the HLM meeting was 30 million people by 2022. That would require a ramp up of 6 million people enrolled on preventive therapy per year over the next 5 years. Today's landmark agreement that we're announcing is an emphatic response to that call to action. It's translating political commitment to tangible action. Up to now, rifapentine, a medicine recommended by the World Health Organization to be used in conjunction with isoniazid as a more effective TB preventive therapy, particularly in those most vulnerable, people living with HIV, and all household contacts, irrespective of age, of those with TB, has been out of reach of those who most need it. And among other things, a key barrier has been price. It has been prohibitively expensive. It has been unaffordable. What this announcement demonstrates is an agreement reflecting a public-private partnership with Sanofi, Unitaid, and the Global Fund to fight AIDS, TB, and malaria, supported by several other key partners, that has enabled us to reduce the price by nearly 70%, from $45 to $15 for a full course of 3 months treatment with rifapentine and isoniazid. Compare that to anywhere between 12 months and 36 months of daily treatment with isoniazid and many more side effects, and very poor adherence and actual global rollout. The agreement means that major development partners such as the Global Fund, PEPFAR, USAID, the Global Drug Facility, arm of the Stop TB Partnership, are now poised to actually roll out a much more effective preventive therapy regimen in multiple high-burden TB and TB-HIV countries starting next year. It's important to mention that at the same time as concluding and negotiating this agreement, Unitaid and partners have been working expeditiously to ensure that we have additional companies coming into the market for rifapentine. This is key so that we have supply security, so that we have enough capacity to meet growing demand, which will surely come after this announcement, and that we have competition down the line. So it's a really landmark agreement that we're happy to share with you today. And Unitaid would certainly like to thank all the key partners that made this possible. Obviously Sanofi, here to my left, and you'll hear from Sanofi shortly. The Global Fund, which was a key partner in working with Unitaid to negotiate this agreement with Sanofi. Our partner Aurum Institute and the consortium of partners that they work who have been preparing countries, more than 12 high-burden countries, for the actual introduction of this product next year. It doesn't happen automatically. Policies need to be changed, sites need to be identified, people need to be trained to ensure that once product reaches the country, it doesn't sit on shelves. It gets out there to the people that need it. I'd like to thank the Stop TB Partnership and GDF, who have been a strong supporter of this process. PEPFAR, who a year ago made a very clear commitment to set ambitious targets in their country operational planning for 2019, and they did exactly that. Obviously to USAID and our civil society partners who continuously ask for more and hold us accountable to bring the best we can bring. The government of South Africa has been particularly influential and supportive in this process by signaling that they're prepared to pioneer and move at scale, not pilot, at scale, starting next year. Obviously, the government of India for hosting this meeting and for being a close collaborator as well. And lastly, to all my colleagues at Unitaid who work and have worked tirelessly to make this agreement a reality. Thank you.
Thank you, Robert. I'm sure we'll get a lot of questions related to this announcement later. Now I would like to invite Thibault Leffert, Head of Sanofi Global Health Business. I would like him to provide some perspective on the announcement.
Thank you. Thank you very much for the opportunity to highlight and explain a little bit what's behind and how this deal is going to work. It's great to see so much excitement about around prevention. I tell you, as a company that's been involved into tuberculosis for so long, we are really happy to be here this day with our partners. For the past 60 years, Sanofi has been a very active player in the field of tuberculosis. 60 years ago exactly, we synthesized rifampicin for the first time ever. Then we worked on fixed dose combinations that were quickly adopted by countries for treatment of active TB. We were also active in building awareness, building knowledge around the disease, partnering with governments, South Africa around our wide-ranging TB-free initiative for patients. And only this week, we are announcing the launch of our website, ltbi.com, for general information about latent tuberculosis towards patients. And we just also announced a partnership with the union around e-learning modules for healthcare professionals around latent TB. So, but with rifampicin specifically and with latent TB, we've been in a bind for a while. This product has been available for quite some time, but adoption has been very slow. We've had clinical evidence brought up together with our partners that has demonstrated the value of the 3HP regimen. We are, as Robert mentioned, much faster. We have the fastest regimen, only 12 intakes over 3 months versus 6 to 9 months or more of daily intakes. So we bring convenience, we deliver patient adherence, which is key for prevention. And in spite of this, figures have remained slow due to a number of barriers. We recognize that cost was one of these barriers. And that's why we're extremely proud to be announcing today this initiative. This innovative mechanism that has been developed together with Unitaid, with Global Fund, and with the other partners allows us to do what we were not able to do so far. We are fast-forwarding the market development to a point directly where patients and programs will be able to have access to an affordable treatment at the prices that generic companies would actually bring. And we're able to do that now because we are sharing risks, because we have been able to turn the problem on its head. That's really significant. We won't stop here, obviously. We're still working on development. We will stay very active in the field of education, assuming our responsibility. We are still pursuing development of pediatric forms, which are critical also, which have been missing. And we will bring these to the market. We also welcome very much the arrival of additional players in rifampicin. The 30 million patients that Robert mentioned, as Sanofi, we will absolutely not be able to satisfy demand, far from that. So we hope that these more people will come and that this deal will create an incentive, a sustainable incentive for the mature development of this market. But I would say price was one of the barriers. It was a barrier. It's one of the barriers. So we need all the barriers to be lifted. We need programs to, we need country programs to take up on their pledge, to act on their promises. We need things to start up. We are removing a roadblock, yes, today together with our partners. Now we really hope that we can help countries and help patients improve general TB outcome. And we are absolutely committed to remaining one of the key partners in the fight to eliminate TB. Thank you.
Thank you, Thibault. And now to the final speaker and another big announcement. Our final speaker is Peter Kim. Peter is director of the Division of the AIDS Therapeutics Research Program at the National Institute of Allergy and Infectious Diseases within the National Institute of Health in the US. Peter will talk briefly to a new trial announcement by the NIH around MDR-TB prevention. Peter, please go ahead.
Thank you. It's really a pleasure to be here today, and thank you for the opportunity to speak with all of you and all those on the internet. As you know, prevention is such a key part of any infectious disease, but for TB, it is especially so. TB, as you know, is one of the oldest infectious diseases known to mankind, but yet today, it is actually the #1 infectious disease cause of mortality around the world. And it's actually, while it's taken us a really long time to get to this point where we are today, it is actually really exciting that we are here. I think there's a palpable excitement among the attendees of these conferences about some of these advances that have been made, represented by the presenters here. It's really just an exciting thing to see. We are here, though, to announce, or I am here to announce, a new phase 3 global clinical trial to look at how we can prevent MDR-TB in those that have been exposed to MDR-TB cases. Though we have actually made significant advancements, as you can see, in the prevention of TB, one critical gap that still remains is how do we prevent MDR-TB in those that have been exposed to those with MDR-TB disease. Despite the years of research that have been done on new treatments for MDR-TB, we still don't know what we can do to prevent MDR-TB. So this new clinical phase 3 global trial will answer that question. It's a $70 million investment from the NIH. It's actually a collaboration, public-private partnership between us and the Otsuka drug company to test whether this new drug, the Latent, will be effective in preventing MDR-TB among household contacts. This study actually involves both adults and children and will hopefully once and for all answer the question of how do we prevent MDR-TB among household contacts that have been exposed to MDR-TB. I'd just like to also add that this clinical trial is being rolled out in 12 different countries around the world. And those countries are India, Kenya, Uganda, Botswana, Brazil, Haiti, Peru, Philippines, South Africa, Tanzania, Thailand, and Zimbabwe. And the reason is that this is important is because we at the NIH believe that what we need to do is come up with tools, strategies, and answers for TB that work for the global disease of TB and not just in local settings. Because TB is a global disease, we need to come up with answers that will work globally. And we are committed to understanding and advancing science that's going to help us answer these questions, both just on our own, but of course, more importantly, in partnership with global investors, global funding partners, and also the researchers themselves that are around the world really are the ones that are doing this work. And we just want to thank all of our partners, including some of the people that are represented here today, and also the government of India. We have a very strong partnership with the Department of Biotechnology in advancing other types of research that we think in the future are going to play a critical role in helping innovate new technologies to prevent TB. And I'm really thankful to be here today, and I think this is going to be just the beginning of really a new phase in ending the TB epidemic. Thank you.
Thank you, Peter. We have 15 questions for question and answers. I think we'll be happy to take questions. We have microphones set up on both sides of the room. I'd request you to state your name, the media outlet, and the person you're directing your questions to. Yes, madam.
Hello, I'm Times of India. This question is for Dr. Valerie. Could you tell us if these children were also given some sort of nutritional support and if they suffered any sort of side effects, and how many doses, as in how many doses are you talking about in a day? When this were these oral formulations, they had to take it. So was it once a day, twice a day?
Okay, so do you hear me?
Yeah.
Okay, that's better. Well, the intervention was not including any nutritional support because it was really only focused on TB, unfortunately. But we had quite a large proportion of malnourished children in the community, where 7% of them were severely malnourished, and actually 15% of them were had moderate malnutrition. The treatment itself was the daily treatment. That was a tablet to take every day, and the parents were given the provision of treatment for 1 month, and they would watch the child taking it every day. And it was a dispersible. It's a formulation which is child-friendly. It's dispersible. You can mix it with everything you want, and it's quite palatable. Usually, children like it, so it was quite easy to give. And the parents were recording what the parents the number of days that they missed every month, and usually they take it very regularly because the families were followed up every month during treatment, and then after that every 3 months.
And you did not see any side effects?
Oh, sorry. The side effects were actually quite mild. We were recorded about 2% of children having, families reporting side effects in children. Mostly nausea or gastric discomfort, and this was only what we did. The problem with preventive treatment and the fear of everybody is the hepatotoxicity. And there was only one report of one hepatotoxicity possible problem in the whole cohort with the 6 months isoniazid regimen.
Thank you.
Can you please take the mic, madam? If you can let us know whom you are directing to the question.
Dr. Kim. For Dr. Kim. Sir, I'm Sheila Crisostoma from the Philippines. Sir, you mentioned that the Philippines will be one of the 12 countries that will be part of the study. How many participants will come from the Philippines? And in case this becomes successful, how will this benefit Filipino patients in terms of access to the medicines?
That's a great question. So in terms of how many participants, it's very difficult to say. We hope many will be enrolled, but right now we don't have limits on how many participants can be enrolled at each particular site. So I don't know what the answer is, because the clinical trial, we'll only know once the clinical trial is fully enrolled how many participants were enrolled in the Philippines. But right now, we hope many patients will be enrolled in the Philippines. The total sample size for this trial is over 5,600 participants. So I think there's actually ample room for Filipino patients to be involved in this trial. And actually, I would encourage patients from all of the countries where we're operating to get involved, because I think this is such an important question. In terms of access to the drug, from what I understand, this is not my area. We're focused on the research itself. But from what I understand, Otsuka actually is very involved in working with the Filipino government towards this end. So I'm hopeful that once we prove that the laminate works, that it will be made available without any restrictions in the Philippines.
Sir, why the Philippines? Why did you choose the Philippines?
Why did we choose the Philippines? Actually, for many reasons. One is that in the Philippines, there is clearly an issue with TB, especially MDR-TB. Number two, the Philippines had actually a really good clinical research infrastructure that was already there, so that we can go in and do the trial in the Philippines without having to overly invest in development of a new clinical research site. And number three, I think that it was important to us that we have a clinical trial that is globally representative. And so Philippines being a major area of TB in Asia, we thought it's important that Philippines is represented.
Sir, has this
Can
been
I leave it to the last
follow-up?
question? We have others. Yeah.
Sheila, we need a few other questions. Sorry. You can
Yeah,
focus on
please.
one to one.
Thank you so much. I'm Ilu, from a journalist from Hong Kong Phoenix Weekly. I have a question for Mr. Lelford. I'm very excited to hear the lower price today, but I have a question because I know that rifapentine is also a part of a first-line drug for the TB treatment. So I think the lower price could also increase the affordability for the TB patients. So my question is, why did you emphasize so much on the efforts to treat the latent TB infection rather than the treat for the patients?
Thank you for the question. So our efforts right now, it is true, have been focused for quite some time on treatment of latent TB, on prevention of active TB. Although initially rifapentine was developed as a drug for active TB, but it has been found extremely active, extremely interesting for the prevention, and that's why we've been more active in the field of prevention. We have clinical research ongoing in the field of drug-sensitive active TB, with results. I think preliminary results starting to come next year, and we hope to have great things to announce then, in order of in the field of especially in the field of reducing significantly the duration of treatment. So that we hope to come back with great news. Obviously, what we are talking here is price of rifapentine for the usage. Our commitment is to reduce the price of rifapentine itself. It's not attached specifically to prevention or to active TB. It happens so that in most countries today, the usage that is developed by national programs is around prevention, but it's valid for every aspect of the drug.
Hi, I'm Snigdha from New Delhi TV and Go News. My question, I think, is for Robert. Robert, could you elaborate on the pricing for rifampicin in India, and also will it be rolled out on a donation basis like how bedaquiline was, and for how many courses?
Thank you. So the price discount is available to 100 countries, including India. These countries account for more than 90% of the burden of TB, HIV, and where preventive therapy with this regimen will be required. In terms of how the product will be financed, the majority of the financing will come from multilateral and bilateral programs that support national governments as well as national government funding itself. By that I mean the Global Fund, PEPFAR, USAID, national government monies, which we would expect to come from a number of upper middle income countries and even lower middle income countries in combination with development finance assistance. So it's not a donation program, it's a discount that's intended to be introduced to routine programs which have already identified financing for TB prevention as a priority. And we know that dozens of countries have identified this as a priority and are working with their development financing partners to identify the resourcing that will enable them to kickstart the rollout of preventive therapy with this medicine next year.
A quick, could you briefly also give us a timeline about how it will be rolled out in South Africa?
I can't speak for the government of South Africa, but we work closely with the government of South Africa. South Africa is poised to be the largest program that will pioneer the rollout and scale-up of rifapentine-based therapy. They are working very hard with our partners and with their funding partners to hopefully kickstart the rollout in Q2 next year. Given the scale that they're looking at, a lot of preparation has to be done in terms of the sites, the training, the rollout, the regimen switch. But when they move, they will be the largest country to move with this regimen.
All right. We have another question on the right.
Yes,
here.
hi. This question is to either. Oh, my name is Vidya Krishnan. I'm a freelance journalist from India. And this question is to someone either from Utsuka or NIH. If you could explain, so Delaminate was registered in India last year after a lot of pushback from civil society to have it registered in India. So my question is about this criticism that high burden countries are used for research and data is collected, but eventually when the drug is made available, the price point is just completely unaffordable to patients in high burden countries. If you could talk about that.
Well, unfortunately, I can't talk about the price point of what the laminate may be because that, I think, will be up to Otsuka. What I can say is I hope that several years from now, when I'm hopefully up here again to announce the results of the trial that I just announced today, that perhaps the person sitting next to me will be the Otsuka representative talking about the prices for the laminate. But at this point, that's not something that I can talk about because that's not really my realm. I work for the National Institutes of Health of the US, and so that's not something that I can speak to at this point.
Do we have more questions, or can we wind up? Yeah. All right, then. Thank you all very much. I would like to thank the present speakers here for the very enriching and interesting participation from the audience as well. I think if you have further questions, you can interact with them on a one-to-one basis.